So next, I'm going to talk about clean and dirty bone margins and how they may affect clinical outcomes. So I'm not going to say very much about the foot classification system again, except to talk about how antibiotic dosing is recommended, exactly what Edgar talked about. And then I'm going to really finish and focus on discussing outcomes of residual versus resected diabetic foot osteomyelitis. So I guess I want to start by saying exactly what the last speaker pointed out. A lot of what we believe about diabetic foot osteomyelitis is based on really small studies. Most studies have less than 50 people in each treatment arm. If you were trying to get funding from the NIH, this would be okay preliminary data, but there are very few large, robust clinical trials. I think the other thing you have to ask yourself is this your patient population? The patient selection is really heterogeneous. There are studies who systematically eliminate everyone with peripheral vascular disease. Well, I mean, that's all my patients. Sometimes they eliminate people that require surgery or have an abscess. So, not all of these studies are comparable. People use interesting definitions of what osteomyelitis is. I reviewed a study the other day that said they defined osteomyelitis by having a positive bone culture, except a third of their patients didn't have a positive bone culture, and they analyzed them anyway. And then I think you have to look at the definition of what successful treatment is. Many of these studies use wound healing or no recurrent ulceration as a measure of successful treatment for osteomyelitis. Most studies don't use if they have another infection, and specifically if they have another infection of the bone at the site of the previous infection. So there's some studies, if you get a foot infection again on that foot, it's counted as a failure. And it may just be a different, it's like if you have flu 3 times, the flu you have the third time is unrelated probably to the flu you had the first time. It's not always related events. Okay, so again, I think this is important because it helps you identify severity. It helps you plan or understand resource utilization. And I think it helps you sit down and talk to your patient and let them know how severe their wound is and what their outcomes are likely to be. What we don't include in this, because this is such a complex issue, is our patients have bad vascular disease. Their wound's not going to heal because they have underlying osteomyelitis. They're going to not heal because they have an indirect bypass to their foot or they're not bypassable. It has nothing to do with their previous bone infection. So some of those things like A1C and if they have vascular disease or not is too complex with something that's already pretty well layered. So why does shortening your antibiotics make a difference? I mean, why do you care? Maybe we should just give everyone 6 weeks of antibiotics. I mean, if you look at this, and this is data that Edgar presented, I mean, the old guidelines, maybe 2 versions ago, that if there was no surgery or dead bone, the treatment was 12 weeks. So, I mean, again, these are often expert discussion. Now we have a few more clinical trials, but we still need large, robust studies in this group, like the Aviva study. So why do you care if you've resected all the osteomyelitis or not? So thank you for this, Edgar, I stole this. Is because the reason we're interested in antibiotic stewardship is because there are serious adverse events, sometimes life-threatening events, that are associated with just to be safe, I'm going to give you 2 months more of antibiotics. Acute kidney injury is common, not always antibiotic related. Line complications can be very high. We can create antibiotic resistant pathogens. C. diff, not as common, but when it happens, it's a really difficult and unpleasant event for everyone. So when's surgery necessary? So I think a lot of studies that compare just treating people with antibiotics versus treating people with antibiotics and surgery, you can't compare the two groups because of the exclusion criteria for people that just get treated medically. And so one of my problems with the Aviva study is, more details. It's like, I want to know, did they have surgery? Did they, more details in that subgroup. So, it's not always as obvious as, pus on your face that someone needs to be opened. But certainly, you're not going to include someone that just gets antibiotic therapy if they have a deep abscess, dead tissue, necrosis, ascending cellulitis, or gas in their foot. It's not a clinical choice unless the patient says that's what they want. Or if bone is sticking out of their foot, you're not going to heal over that exposed metatarsal bone. So one of the things, so this is a few descriptive studies. Mostly these are retrospective cohort studies. But if you look at antibiotic utilization, or if you look at the remission rate, and the definition of remission is all over the place. Many are things that I would not use as a measure of success. But the duration of antibiotics is not 6 weeks. It's usually way longer than 6 weeks. And that's what we saw at a large hospital. A lot of times, so we eventually got an ID person that was a musculoskeletal person. Now, she would rotate off periodically, and you'd get the guy who has focused on HIV, and he was pissed that he got assigned to do musculoskeletal rounds, and so everyone got 5 antibiotics, and it's like, settle down. It's and longer periods of antibiotic treatment. So not what happens in the world isn't usually based on guidelines. And when I talk to our ID people, they were oblivious to the IDSA guidelines. So I gave it to them, and I know there's a lot for them to keep track of, and we love this, so we think everyone should love it. So so I think I was at least trained. You need to go resect all the infected bone, all the infected tissue, then we'll deal with the deformity that you created or was created from the infection. So this is just a look at people that had their great toe amputation. So after you have your great toe amputation, there are more structural deformities, hammering of the toes, dislocating of the lesser metatarsal phalangeal joints, and new ulcer formation on the amputated foot compared to their contralateral side. So people will spend the next year with a beautiful straight foot and a claw that is accommodating for their lost great toe immediately. So do we have a choice for these people? Sometimes we do. Sometimes they have chronic osteomyelitis, and it's like, they have osteomyelitis, we need to cut your toe off. Well, for sure, if we amputate your big toe, you are going to have difficulty. It is hard to find any magical shoe or insole or brace that's going to accommodate that dynamic structural deformity that we help to create. Someone has a big abscess, dead tissue. I think your hand is forced. The other thing we know is, let me show you I'll show you the peak pressures in just a second. So, we increase structural deformity, we increase foot pressures, and you can see the change compared to the contralateral foot of their second toe, their second metatarsophalangeal joint, their third toe, their third metatarsophalangeal joint. And one of the things, this isn't just great toe amputations. These are people that have sensory neuropathy compared to patients that have had any foot amputation. So one of the things, a beautiful bell-shaped curve, right? One of the things we do when we amputate your foot is we have a nice shift of pressure to the right. Your foot's not functioning well. And so there's no tail on this. It's just all high pressure. So most of the literature suggests that most of the people that have a foot ulcer, most of the people that have a foot amputation, those are the two highest risk factors for people having another event. If you look at people that just have neuropathy and structural foot deformity, about 3% of those people develop an ulcer when they get preventive care. If you've had a previous ulcer amputation, if you get preventive care, you see a podiatrist on a regular basis, you have education, a third of those people will re-ulcerate, a third to a 40% will re-ulcerate the next year. So, so perhaps looking for a clean margin or a dirty margin that is a better functioning biomechanical foot is a good choice if the treatment outcomes are the same. I was really trained, medical treatment for osteomyelitis doesn't work. We need to cut it all. We never got a clean margin. No one ever proved that we got rid of all the infection. So two clinical studies that compare surgical and non-surgical events. This is a retrospective study, small study, 34 and 35 people in each treatment arm. The medical treatment, 57% of people healed in a year. The duration of healing was 462 days. The duration of antibiotics was 247 days, a little more than the 6-week treatment period. They required a second surgery 40% of the time. All those events are better in the medical and surgical group. Now, I don't think all these, I don't know if you can really compare these. It was a convenient comparison. So this is a randomized clinical study, prospective study, 24 people in each treatment arm, small study. They looked at 12 weeks of follow-up. I don't think you can evaluate osteomyelitis with a 12-week follow-up. They had people that got surgery had 10 days of antibiotics after their surgery, and then they stopped. There was no difference in their primary healing. That was their measure of success if the wound healed. Had nothing to do with osteomyelitis or not. The time to healing was no difference in minor amputations. So a positive retrospective study, a negative prospective study. And then there's a couple dosing studies that I think are interesting. Again, relatively small study. Tone from Eric Somerville's group, they looked at 40 patients, 60% at 6 weeks versus 70% healing at 12 weeks for people that are for successful treatment. And their successful treatment was reinfection. And then comparing 3 weeks of antibiotics to 6 weeks of antibiotics, no difference. So I think this is the study that I think kind of shifted the guidelines from if you resect bone, you can shorten your antibiotic course. We need better data. So I think, again, you have to go and decide how clean bone margins are defined, just like you have to define people with osteomyelitis. I think that usually defines, or we have used, negative bone cultures and negative histology. So there's a paper that was published in Foot and Ankle Surgery. It was from Scott and White in Temple, Texas, and they have a scoring system for the histopathology of osteomyelitis. I think this is a nice framework, but I think what's important is you sit down with your pathologist and say, what criteria are you looking for to say if there's osteomyelitis or not? Would you please document that? Because I get horrible reports that are like, the assessment is consistent with the diagnosis rendered. And I'm like, what the hell does that mean? That I said it was osteomyelitis, so it's osteomyelitis, or I said it was a clean bone margin, so I think you need to sit down with your pathologist and identify. There's one or two pretty good papers about histologic criteria, but I think it's defining how you're going to assess these together, and also providing a better information to the pathologist when they read this, so they're not doing this in a vacuum. So what we do for a clean bone margin is after we do the IND, after we irrigate the surgical site, we use clean instruments. The guys at Georgetown change out their whole back table. I don't think you need to do that. We remove external gloves, we retract the soft tissue so we can get a good piece of bone. We collect the bone, and then the surgeon places the bone in the specimen cup, and we don't let the person on the back table, play with your specimen. Histology, they can do whatever they want with, and it just goes in the histology specimen. So this was a review that Mario Reyes did in our group that was just recently published. So you can see there's a growing body of work where people are looking at clean versus dirty bone margins. Most of it is from the United States. you can see that, the number of patients is with their healing wounds, amputations, and reinfections, are mostly provided. It's a still some of the things that I want to see, like reinfection, are not included in some of the studies. So that really cuts our meta-analysis, or the power of our meta-analysis, down quite a bit. So this is just a description of the clinical studies. I mean, some people just use histology. Some people use clinical symptoms and probe the bone and a compilation of different criteria instead of the gold standard. So you really have to, scrutinize the data you're trying to interpret. 2 prospective studies. Everything else is retrospective. So if you look at this, and I think some of this is a self-fulfilling prophecy. If you get a clean bone margin and you believe the IDSA guidelines, you stop your antibiotics, so you have a shorter duration of antibiotics. I can tell you, our ID people didn't do that. They didn't believe the clean bone margins, or they didn't want to, follow the guidelines, even after we shared the guidelines. So whether there's residual osteomyelitis or not, there was no effect on antibiotics. You're 4 times more likely to have an amputation if you have residual osteomyelitis. Again, that could be a self-fulfilling prophecy that you have residual infection, I need to cut it out. People that had residual osteomyelitis had longer duration antibiotics treatment, and the risk of reinfection was 2 times higher if you had residual osteomyelitis in these studies. But since we did this, there are 2 other studies that had been published. One was in CID, or open form of infectious disease, where they looked at 92 people. They looked at 57 people that had clear margin and 35 people with residual osteomyelitis. They used positive histology with reports of inflammation or leukocyte infiltration in the bone as their criteria for clear margins or not culture. There was no stopping rules for antibiotics. And the success was based on if you didn't require an amputation, not on reinfection, not on wound healing, but if you had an amputation or not. So I don't know if I'm buying that. So no amputation in 12 months. There was a significant difference in the people that had clean bone margins. No amputation at 6 months. There was not a significant difference. Readmission was higher in people that had residual osteomyelitis, and antibiotic duration was higher in people that had residual osteomyelitis. Now, we did a post-hoc analysis of patients that were in RTCs. So their data was prospectively collected. We have kind of stuck with our operational definitions of what a bone infection is or not. We had 171 people, 79 had no bone infection, 92 had residual osteomyelitis. Everyone had a combination of skin and soft tissue infection. If you look at our reinfection rate, it was 19% in people that had bone margin, 21% in the people that had residual osteomyelitis. No difference in the other parameters. Here's the survival analysis for reinfection. I kind of showed you this before, and this is the healing survival analysis, really overlapping survival analysis for wound healing. Oh gosh, I'm going the wrong way. If you break down reinfection into soft tissue and bone, 13% in bone infections, and if it was clean or dirty bone margins. So a low rate of reinfection compared to other studies. I think part of this was having a multi-specialty team. We really don't talk about revascularization here, but we have really good vascular surgeons. We had an ID person who was really interested in musculoskeletal disease, and we had a podiatry team that really was the primary caretakers. So, I think it's really inexpensive to get a bone biopsy. You're going to get pathogens, you're going to get sensitivities, you're going to get a definitive diagnosis. You may be able to cut your duration of antibiotics just by eliminating that people have a bone infection with something high level. There's a lot of false positives in people that have MRs. We should have that in the next 6 months, I think. I think the duration of antibiotics probably depends on the extent of surgery. but it also depends on the belief system of the ID people you use, or your belief system if you're writing for oral antibiotics. So, the two largest studies have not been included in meta-analysis. We'll see if this changes things very much in the future. But with that, I'll finish and thank you for your attention.